Proptosis. Clinical picture. Forward displacement of the eye, which may be unilateral or bilateral. Common causes are thyroid eye disease, orbital tumors, infections such as orbital cellulitis, trauma such as orbital hemorrhage, orbital cellulitis, also known as inflammatory proptosis. Diagnosis. Basic inspection of the eye to see if there is protrusion. Exophthalmometry, a clinical method used to measure anterior displacement of the globe. CT MRI scan of orbits. Treatment includes treating the underlying causes such as Graves' syndrome and infection, lubrication for exposed eye, steroids to help with inflammatory reactions, surgical decompression in severe cases. Graves' disease. Bilateral proptosis of the eye associated with lid retraction, a lid lag, and a staring look. Etiology of Graves' disease is that the autoimmune antibodies stimulate orbital fibroblasts, which leads to fat and muscle enlargements around the orbits, the extraocular muscles and the intraocular muscles. Diagnosis for Graves' disease would be by doing regular thyroid function tests along with an orbital CT scan, see muscle enlargements with descendants. Another way you could diagnose this is by going after the clinical signs which were mentioned in the clinical picture, which is the staring look, the dry eyes, and the lid retraction. Treatment for this would be to try to control the thyroid status, dropping artificial tears on the eye to lubricate it every once in a while, steroids within the active phase, orbital decompression within severe cases, just like proptosis. Hordeolum consists of painful red localized swelling on eyelid with acute onset. Causes are due to staphylococcal infection, such as infection of the Mall gland or the Meibomian gland. Treatment Treatment consists of warm compress, topical antibiotics, incision and drainage if persistent. Ptosis. Drooping of the upper eyelid, which may be bilateral or unilateral, and can obstruct the vision. It is due to oculomotor nerve palsy, which causes severe ptosis, myasthenia gravis, aponeurotic, which occurs in senile age, and it may also just be a congenital defect of the levator muscle. Diagnosis relies heavily on just looking for any asymmetry between both eyes, assessing the levator muscle function, and sometimes measuring the palpebral fissure height. Treatment for this would be treating the underlying causes such as myasthenia gravis. You'd get some anticholinesterase plus some immunotherapy. If you have cranial nerve 3 oculomotor nerve palsy, you do an urgent neurological evaluation. If it's Horner syndrome, then you'd have to investigate the cause. Blepharitis. It is a chronic inflammation of the eyelid margins. Patients usually complain of itching, burning, redness, and a foreign body sensation in the eyes. They often complain of sticky eyelids on waking. During examination, there is redness of the lid margins with crusting or scales at the base of the eyelashes. In posterior cases, you may also see signs of meibomian gland dysfunction with thickened secretions associated with dry eyes. Etiology depends on the type. Now, we all know that there is two types of blepharitis, anterior and posterior. Anterior is due to staphylococcal infection, while posterior is due to meibomian gland dysfunction, which leads to abnormal lipid secretion, often associated with poor lid hygiene. Diagnosis is mainly clinical. A slit lamp examination will show inflammation of the lid margins, debris around the eyelashes, and in posterior cases, plugging of the meibomian glands, which means that they're obstructed. No routine investigations are usually required. Treatment is very long-term and requires patient compliance. Management includes regular eyelid hygiene using warm compress, which is the most important, followed by gentle lid scrubbing. Topical antibiotics such as erythromycin can also be used in anterior blepharitis. Artificial tears would help with the associated dry eye symptoms. Since this is a chronic condition, maintenance therapy is essential to prevent recurrence. Gallésion. Gallésion is a chronic localized swelling of the eyelid. Patients usually present with a painless lump that develops gradually over weeks. Unlike acute infections, there is typically minimal redness and no significant tenderness. Gallésion occurs due to obstruction of a meibomian gland duct. leading to retention of lipid secretions. Over time, this triggers a chronic lipogranulomatous inflammatory reaction. Treatment of chalazion is mainly conservative at first because it is a chronic sterile inflammation, not an infection. We start with warm compresses applied for about 5 to 10 minutes, 2 to 3 times daily. This helps to liquefy the retained lipid. This is followed by lid massage to promote drainage along with good lid hygiene. Most chalazion resolve within a few weeks with this approach. If the lesion persists, the next step is intralesional steroid injection, which helps reduce the granulomatous inflammation. For larger or long-standing lesions, the definitive treatment is incision, performed from the conjunctival side. Antibiotics are not routinely indicated unless there is an associated infection. Entropion and ectropion. So before we get into this, we need to cover up one common misunderstanding, and that is that entropion is that the eyelid turns inward. So the eyelashes will start causing ulcers on the eye, while ectropion is that the eyelid, the lower eyelid, turns outwards. Now that that's out of the way, we're going to start with entropion. Entropion is an inward turning of the eyelid margin, most commonly affecting the lower eyelid. Patients typically present with irritation, redness, tearing, and a foreign body sensation. A key feature is trichiasis, where the eyelashes rub against the cornea, leading to abrasions or even ulcers. On examination, you'll see inward rotation of the lid margin, and in chronic cases, you might even see corneal scarring or vascularization. Treatment depends on severity and underlying causes. Conservative treatment includes lubricating eye drops and ointments to protect the cornea. Temporary, Temporary measures include taping the eyelid and botulinum toxin injection to weaken the orbicularis muscle. Definitive treatment is surgical. Lagophthalmos. Lagophthalmos is the inability to fully close the eyelids, either partially or completely. Patients present with dryness, irritation, redness, and a foreign body sensation. A key feature is exposure of the cornea, especially during sleep. On examination, you'll see incomplete lid closure, sometimes with a visible gap and often a positive Bell's phenomenon, where the globe rolls upward on attempted closure. In advanced cases, there may be corneal epithelial defects such as ulcers or scarring. Diagnosis is primarily clinical. Observe the patients attempting to close their eye and notice any residual gap between the eyelids. Assessing the degree of lagophthalmos in millimeters. Evaluate facial nerve function, including forehead movement and eye closure strength. Also assess for proptosis or eyelid scarring, depending on the suspected cause. Management focuses on protecting the cornea and addressing the root cause. Treatment includes frequent lubricating drops during the day and ointments at night. Patients may benefit from eyelid taping during sleep or a moisture chamber. Acrocystitis. Acrocystitis is an infection of the lacrimal sac due to obstruction of the nasolacrimal ducts. Patients present with pain, redness, and swelling over the medial canthus just below the inner corner of the eye. Key signs include tenderness and a fluctuant swelling. When you press over the lacrimal sac, you may see purulent discharge regurgitating through the punctum. Patients often complain of epiphoria due to impaired tear drainage. The underlying cause is nasolacrimal duct obstruction leading to secondary infection. Common organisms include Staphylococcus aureus and Streptococcus pneumonia. Congenital obstruction can occur in infants due to failure of canalization. Other causes include trauma, nasal pathology, or tumors obstructing the drainage system. Diagnosis is mainly clinical. Key findings include medial canthus swelling, tenderness, and pus regurgitation with pressure over the lacrimal sac. The regurgitation test is particularly diagnostic. In chronic cases, tests like the fluorescein dye disappearance test can assess tear drainage. Management depends on whether the condition is acute or chronic. Acute dacryocystitis is treated with systemic antibiotics, warm compresses, and analgesia. If an abscess forms, incision and drainage is required. Definitive treatment is dacryocystorynostomy, which creates a new drainage pathway between the lacrimal sac and the nasal cavity. That's it. Thank you guys for watching. See you on the next one.